Good evening, and welcome to the second in the series of BostonSight Scleral webinars for this year. As was the case last time, just as an FYI, this webinar will be recorded, and we will share with you a link of the recording afterwards in case you wanted to revisit any things that were mentioned here. Tonight, we will learn how the evidence-based nature of BostonSight Scleral can help you streamline and make it easy to navigate scleral shape. Also, with Eaglet Eye's first fit algorithm, image-guided fitting is now a reality for larger diameter lenses, streamlining further scleral shape while affording patients the best comfort and long-term health. We are very pleased tonight to have Drs. Melanie Forgozo and Dr. John Gelly share their experiences and clinical insights. As an introduction, let me introduce Dr. Melanie Forgozo. She is the owner of Alamo Eye Care and the Contact Lens Institute of San Antonio. She completed a residency in cornea and contact lenses at the University of Houston College of Optometry, and afterwards took a faculty position with the University of Iowa Department of Ophthalmology and Visual Sciences, where she continued to develop her specialty. In 2013, she returned to Texas and opened an independent clinic dedicated to specialty and medical contact lenses. Dr. Forgozo's expertise is managing very complex corneal conditions with specialty contact lenses in both pediatric and adult patients. Her additional interests include dry eye disease and myopia management. She is a fellow of the American Academy of Optometry and is a diplomate in the Cornea Contact Lens and Refractive Technologies section. Also, she is a fellow of the Scleral Lens Education Society, an advisory board member for the Gas Permeable Lens Institute, a member for the Contact Lens section of the American Optometric Association, a member of the International Society of Contact Lens Specialists, and a member of the Texas Optometric Association. She also serves as an adjunct clinical professor for the University of Incarnate Word Rosenberg School of Optometry. Dr. Gellies is the director of the Specialty Contact Lens Division of the Cornea and Laser Eye Institute, Hirsch Vision Group, and the CLEI Center for Keratoconus in Teaneck, New Jersey. He is a graduate of Pennsylvania College of Optometry and is an adjunct clinical instructor for State University of New York College of Optometry and New England College of Optometry. Additionally, he is an optometric consultant and serves on the executive board of the International Keratoconus Academy of Eye Care Professionals and the advisory board of the Gas Permeable Lens Institute. He is a fellow of the International Academy of Orthokeratology, Contact Lens Society of America, and the Scleral Lens Education Society. His clinical work is dedicated exclusively to specialty contact lenses and surgical co-management for corneal disease, predominantly keratoconus, ocular surface disease, and post-surgical corneal conditions. He is a sub-investigator for multiple keratoconic-specific clinical trials. And as an introduction, here are the financial disclosures for our speakers tonight. And I'll hand it over now to Dr. Forgozo, who will go over the first case of the night.
Thank you so much, Alan, for that introduction. And I want to thank every one of you tonight for giving your time and joining us tonight for this webinar. I'm really excited to share this information about scleral contact lenses, and I'm going to go ahead and get started with the first case of the night. I want to present to you a patient of mine, a 34-year-old female with a history of keratoconus. And as you can see here, that she has been wearing a small diameter lens for the last 3 years, and she was complaining or relating to me that maybe that her vision can be improved, and sometimes the lenses did create irritation. So you can see here she has very advanced keratoconus. Here's a refraction. She doesn't refract very well. And on topography, she has a very, very large cone, the left eye greater than the right eye. When I looked at her from side profile, I could see that she had a very large ocular sagittal depth. And her scleral lenses, or current scleral contact lenses, had also a deep sagittal depth, but they were decentering inferiorly and creating impingement because they were decentering inferiorly. There was impingement, and at 3 and 9 there was also impingement. So this was what was causing the mechanical irritation and redness occasionally. And I thought, looking at her lenses, that she would do much better in a larger diameter scleral lens. So I explained to her the benefits of moving into a larger diameter scleral lenses. I personally like large diameter scleral lenses. They're very, very forgiving. A large diameter lens has a larger landing zone, which distributes the weight across the sclera much more evenly, and so it's a much more forgiving. You can compare a larger diameter lens to a snow boot, which has a wide distribution and can distribute the weight evenly. A smaller diameter lens has a much smaller landing, so a lot of the times these lenses can settle sometimes very harshly into the conjunctival shape and create mechanical irritation. And I actually analogize this to more of a stiletto heel. When you're wearing a stiletto heel, all of the weight is going in one area, and this can be very heavy on one section. So I told the patient the benefits of a larger lens versus a smaller lens, and she said, no, I don't think so. I'd like to go ahead and stay in my comfort zone and continue wearing smaller diameter lenses. So I went ahead and I attempted to fit her into a small diameter lens. I said, okay, let's try a little bit of a bigger lens. Let's try lenses between 15 and 16.5 millimeters. I tried multiple lenses, both spherical landing zones and toric landing zones, and all of the same concerns still persisted in each of these fits. They all decentered inferiorly. There was impingement because of this in that particular quadrant, and there was also impingement at 3 and 9. So finally, she decided, okay, after these multiple refits, we were going to go ahead. She agreed for me to fit her into a larger diameter lens. So I tried an 18 millimeter diameter lens with a spherical haptic, and I decided to try a spherical haptic at first because a lot of the times you can actually fit a spherical haptic over a toric sclera and get away with it, but sometimes you can't. And it's interesting, there's a study that came up in 2018 by Ritzman and his colleagues, and it states actually beyond 15 millimeters, the sclera actually becomes increasingly more asymmetric, so you should consider a toric landing zone. So my next lens I went to was the BostonSight, and I really enjoy fitting this lens because it's actually based on evidence. They took over 7,000 eyes, and from 7,000 eyes, they took the best fitting lenses and they created a fitting set of scleral lenses, and this is the BostonSight Scleral. So this is the fitting set. You can see here what's unique about this fitting set is actually there's lenses for the right eye and the left eye. And this is very unique. When usually you get a fitting set, there's just lenses for all eyes, but this specifically is unique and has symmetry for each eye individually. And it's very important that you actually place the right lens on the right eye and the left lens on the left eye, because they actually have toric peripheries that match the scleral shape. They found with their evidence that the scleral shape is different in the right eye and the left eye respectively. So the main part of the fitting set, as you can see here, has 9 lenses. These lenses are specifically used for fitting. Once you find the right fit, you do an over-refraction. And if you feel like you've found your best corrected visual acuity, then you can move on to order the lens. However, if you think that the vision can be improved, they have actually 2 additional lenses you can see here to the right, which have a different eccentricity value on the front surface, and this can sometimes improve the vision. The lenses are very unique in that they all have numbers, laser engraved. That way, if you accidentally mix up your lenses, they actually have engraved the model number, and then the right and the left lenses actually have markers on them denoting which lens is which. One dot is the right lens, and two dots designates the left lens. And this can also be used later on, I'll share with you in a case, in measuring where the lens stabilizes, and you can add front surface toricity very easily using these markers. So when you're fitting this lens, the first lens that you want to start off with is the lens right in the middle, and this is lens 5. You start off with this lens and you evaluate it on the eye. If you feel like you need to go ahead and increase the sagittal depth, increase the steepness of the lens, you actually move upwards to the second lens on the fitting set. And then if you want to go ahead and decrease the sagittal depth, you'll move to the bottom lens below that. And then you would move left or right depending on if you want to loosen or tighten the haptic. So with my patient, this is exactly what I did. I went ahead and I started off with lens 5, and this lens looked okay on the eye. I saw there that at quadrants 1 and 4, which actually aligned at 3 and 9 o'clock on my patient, there was a little bit of lift. There was vault over the apex of the cornea, but it was a little bit excessive on the right eye. It was 400 microns. And in the periphery, because of her oblate-shaped, her prolate-shaped eye, the peripheral clearance was over 800 microns. In the left eye, because that cone was more pronounced, lens 5, had a little bit less generous clearance, but it did vault over the cornea. And there was a little bit of lift at quadrants 1 and 4, which aligned with my patient at 3 and 9 o'clock on her eye. And again, there was a lot of peripheral vault because of the shape of her eye. Excuse me here. So next, I went ahead and put on a second lens. Because the first lens was fitting and I needed to decrease the sagittal depth, I went ahead and moved downward, but I felt like I needed to tighten the haptics, so I went ahead and moved to the right. So I picked lens 9 for my second choice for my right eye, and for my left eye, because I felt like I needed to just tighten up the haptic a little bit, especially quadrant 1 and 4, I went ahead and chose trial 2, which happened to be lens 6, so I moved over to the right. So upon applanation, this lens actually looked really good on the right eye. The lens actually looked very good in the haptic landing. But I wanted to improve it a little bit more and lift it just a little bit more, which I'll show you how I did in just a little bit. The vault over the cornea looked really great. There was 100 microns of vault. And in the left eye, the lens, there was also 100 microns of vault centrally, but in the periphery, there was still over 800 microns of vault. So this was my best fitting lens. I did an over refraction, and I went over and I went to Fit Connect to make my next order. So I really enjoy working with Fit Connect. I think it's a really great tool because you can actually see what the modifications that you're making instead of asking a consultant saying, I want to go ahead and change the lens by 100 microns in this quadrant and hoping that it gets changed right. You can actually physically see what you're doing in real time. What's also nice about this is that you can change the vault centrally, you can change the haptic in each quadrant, but then you also can change the base curve of the lens. what's additionally powerful about this the software is that it actually allows you to track what lens changes you're making. When you create an order, it'll show you what you chose originally and then how you changed it, and you can actually follow this through time. For patients and your staff, you can actually tell them when their fitting period is up and how many more days they have in their global period. And then you can easily order lenses and replicate lenses just with a click of a button. So this is just an example of what the FitConnect software looks like on lens modification. You can see here that you have control of every quadrant of the lens, all 4 quadrants. On the bottom, you're able to change the base curve of the lens and then also the shadow depth of the lens independent of the base curve, and then also the haptic. So here is actually the example of how you would go ahead and place an order for your scleral contact lenses. It actually shows you the screen where you can follow what orders that you have made. And then here under RX status, that you can actually print out prescriptions for the patient so they know what prescription they're wearing. And then with another click, you can easily refill the prescription. So this is what I ended up doing for my patient. My patient, because she has so much clearance in the periphery, I needed to take that down a little bit. And so the software allowed me to do this by actually steepening the base curve. The standard base curve of all of these lenses are 8 millimeters. But if you steepen up the base curve, you can see here that it actually collapsed the peripheral clearance. And so I was able to decrease the peripheral clearance so that it was a more acceptable fit. So I ended up changing the clearance from, the base curve from 8 millimeters in the right eye to 7.7 millimeters, and then in the left eye to 7.4 millimeters. And this actually made the fit much better. And so I also saw a little bit of blanching on follow-up after I let her go in the lenses. And so I needed to go ahead and increase the clearance in quadrants 2 and 4, which aligned with 3 and 9 o'clock, where she was having more blanching. So I added 100 microns of clearance in quadrant 2 and 50 microns of clearance. And so this is really cool because you can move it up and down and physically see. So the blue line you can see here is the lens, and the red line is actually the changes that you can make. So this was my patient, but I have another example of this, of where I changed it 350 microns. So I decreased 350 microns, which steepened the haptic. You can see here in the first picture on the top upper left and the bottom lower right, I actually flattened the haptic by increasing the sagittal depth in the periphery. So this is a really neat tool in showing you what you're doing exactly with the lens. So this was actually the final fit of my patient in the left eye. You can see here that her vision, originally in her small diameter lenses, her vision was about 20/50. And with the one-sight lens, the BostonSight lens, I was able to get her vision to 20/30. And then in the right eye, her vision actually improved to 20/25, and the periphery looked great. So now I want to go ahead and turn over this to Dr. Gellis.
Perfect. Thank you so much, Melanie. That was a great case. So BostonSight Scleral has also been incorporating other incredible pieces of technology into their armamentarium to help better consult with patients, or excuse me, with doctors, so that they can get the best consultation experience possible, but also incorporating the use of the Eaglet Eye ESP so that you can scan patients' eyes and be able to develop lenses directly from those scans. So going directly from scanned data to a physical lens. It's a pretty incredible algorithm that they worked on, and from what I've been experiencing with them, they've had some great success with it. There's also other portions of the BostonSight Scleral benefits that come along with using this lens, such as the MyFit report, which allows you to get feedback from the patient's experience about their symptoms prior to using BostonSight Scleral and now with using BostonSight Scleral. So it makes you very aware of the successes that you're having with the lenses. You also have Fit Assist, which is a free voucher that allows you to support patients with some financial barriers so that you're able to fit individuals who may not have been able to afford it due to financial issues. And you're able to get a voucher every 12 patients that are fit. Now, I'm going to talk specifically about PeerMed for a moment. Now, PeerMed is a peer-to-peer HIPAA-compliant communication platform. It runs on iOS devices, so your Apple iPhone and your Apple iPad. It's a HIPAA-compliant, secure, and encrypted software that allows you, the practitioner, to communicate directly with the consultants at BostonSight Scleral, not just in real time, but also asynchronously or in anytime communication. So you can either store and forward images and video, or you can do HIPAA compliant messaging or do video. Now, you take your smartphone or iPad and attach it to your slit lamp with your favorite adapter, and then using the PeerMed system, it's as simple as making a compliant call to Karen at BostonSight, which this is me in my office in Teaneck and Karen up in Boston. And we're able to take a look at this patient's eye. This was a patient with severe OSD that was recalcitrant to treatment after Accutane treatments. And you can see everything about this lens, and Karen can evaluate this dynamically in real time with me and give me good suggestions about what to change with the haptic, what to change with, base curves and with sagittal depths, and really coach me on this so that I get the best experience for my patient. So this is a really cool piece of technology that they're utilizing there. Now, what I'm going to speak on real quick, Melanie had a great case incorporating keratoconus. So, one of the indications for scleral lenses is irregular corneas and the visual rehabilitation that we can get with scleral lenses. So for cases like keratoconus, pellucid marginal degeneration, ectasia, post-radial keratectomy, or corneal transplants or various scars. So the patient that I'm going to share tonight, this is a 36-year-old male who had a diagnosis of keratoconus since 2003. They were status post cross-linking and intacs in both eyes. This individual had cross-linking in 2008 in both eyes, and then had dual segments, so a superior and an inferior intact segment placed in both eyes. Now, I was fortunate enough to have the pre and the post-op maps, so you can see what the intacts did to the corneal shape by flattening it about 5 diopters in those areas for that individual. Now, previously, his contact lens history was positive for wearing an RGP, for wearing a hybrid, for wearing a scleral lens since 2012. Now, with his habitual scleral lens, his vision was 20/30 minus. In his right eye and left eye, he had poor wetting and heavy deposits. He was wearing a 15/6 millimeter lens, and when we removed the lens, he would have deep trenching on his conjunctiva due to the impression of the pressure of the lens on the conjunctival shape. he also has recalcitrant MGD and dry eye syndrome. So what was our plan with this individual? Well, we were going to refit him into a BostonSight Scleral while also treating his MGD. So we did hypochlorous acid, cyclosporin 0.1% BID, and thermal meibomian gland expression to really express out those glands. So to give you an idea, this individual, this was his data set here. He has a Kmax of 57.3 diopters and an IS of 19.4 and an anterior chamber depth of 2.84. His left eye has a Kmax of 52.9, an IS of 17.7, and an anterior chamber depth of 2.84 as well. So you can see those IS ratios are pretty significant. When we're looking at the top, it's very flat. The bottom is very steep of these corneas, and he has a very significant steepening on the right eye as compared to the left eye. So we're going to go ahead. We started with fitting him with an 18.5 millimeter BostonSight Scleral lens. We took a look at that lens, and generally it was pretty good. We just needed to flatten the haptic a little bit in quadrants 1 and 2 on the right eye, and 1 and 4 on the left eye, which correspond with the 2 nasal quadrants, the superior and inferior nasal quadrants. We also had to steepen the haptic on the temporal sides 100 microns on the right and left lens, and reduce the sagittal depth about 150 microns with this. So we made all those changes to lens 5 with this. So his first lens was the lens that we went with. We went ahead and ordered the lens in Optimum Extreme, and the first lens we got, let's go ahead and go back here and let's get that video to play. What we got here was, again, kind of heavy depositing that was happening. This, he said, was clean in the morning, and this is the deposits that he ended up with, and the you can see the kind of poor wettability of that lens. So what we did was, in our second revision, we went ahead and added HydraPeg to the lenses to help fight that that depositing as well as that dry surface. Now, speaking to Dr. Fregoso's point about having the different eccentricities in the fitting set, this was extremely helpful to this patient. What we did on this patient was I placed on the low, mid, and high eccentricities on this individual, and then used our wavefront aberrometer to be able to measure out the higher order aberrations and the overall aberrations for this individual. And what we found was, on the left, our FSE1 or 0, which is the low eccentricity lens, created more higher order aberrations, which created a best corrected visual acuity of 20/30 minus. When we did the high eccentricity, the FSE2, it created a visual acuity of 20/30. But with our FSE1, which is the standard eccentricity and the eccentricity that they found looking at the retrospective 7,000 eyes that they had fit with lenses at BostonSight, and they found that this eccentricity was the most commonly helpful eccentricity, and it was indeed for my patient as well. You can see it reduced the higher order aberrations, a significant reduction in coma and spherical aberrations, and created a visual acuity of 20/25 plus for this individual in both eyes. So this was the finalized lens. You can see that we had a great fit here, very great result overall, 20/25 in the right eye, 20/25 in the left eye plus. When we take a look at the vaults, these are very adequate vaults over the cornea. And when we take a look at the OCT, you can get a better idea of this. We ended up having, after settling, and this is his most recent visit with me, this was 16 hours of wear and a year out. He has 186 microns over the apex on the right eye and 200 microns over the apex on the left eye, with 127 microns over the intact segments on the right eye and 154 microns over the intacts on the left eye. So overall, this is with the lens off. You can see we no longer have these deep trenches or these impression rings on these eyes. They're looking perfect. Uncorrected, he's 2200 and 2400 in the eyes respectively. So I'll go ahead and pass it back to Dr. Forgozo.
Thanks, Dr. Gillis. So next I want to go ahead and share another case. Another patient of mine with keratoconus, 74 years old. When I saw him, he was currently wearing a pair of scleral lenses, 18 millimeters large, with a spherical landing. His vision was about 20/50 in the right eye and 20/50 in the left eye, but he could pinhole much better to 20/30. So he did have emerging cataracts. You can see here he had a nuclear sclerotic cataract and then cortical spoking. However, since he was able to pinhole to 20/30, his cataract surgeon referred him over and said, okay, well, let's go ahead and try an improvement in his contact lens to see if we can get him better vision instead of doing cataract surgery. So you can see here, this is his corneal topography. As he refracts, he has, against the rule astigmatism, he refracts about 20/50, 20/70, but he does pinhole a lot better. And his current lens design was an 18 millimeter lens, but again, there was impingement at 3 and 9 o'clock, so he had, you could tell just by that, with having a spherical lens on his eye, that he did have scleral toricity, that he was flatter in the horizontal meridian. So I went ahead, knowing that BostonSight Scleral had toricity on all of their lenses, I went ahead and tried this lens out, and I went ahead and I started with trial 1, lens 5 again, and this lens actually looked pretty good to start off with. However, the vault over the central cornea was only about 100 microns, and there was lift in the periphery, again, for the way that this lens aligned on the patient at quadrant 1 and 4. So that was at 3 and 9 for my patient. There was a little bit of lift there. So I went ahead and chose the lens with a steeper landing to the lens right next to it, to the right, which is lens 6. And so this lens actually looked really, really good on his eyes. The edge was completely aligned. The vault, because we went to a slightly steeper edge, that did lift up the central portion of the lens, so he had adequate vault over his cornea, which I felt comfortable with. And I always start with my patients with a spherical refraction, and he was only 20/50 with the spherical over refraction. I said, you know what, something's not right here. Let me just try a score to see what happens. And so on a cylinder over refraction, I did find a significant amount of fill. However, unfortunately, I was able to correct the patient to 20/25 and 20/30, and the patient was incredibly excited about this. However, when I see cylinder over refraction on patients, on scleral lenses, I get a little bit nervous because I know I have to add a front surface toric. And that front surface torics need to be stabilized very well. If not, they're going to induce more astigmatism than you're trying to correct for. So at this point, there is only 2 ways to stabilize toricity on the front surface of a scleral contact lens. The first one is through prism ballast, and this lens is created by the lens being spherical in the back surface, the landing, and then they add prism to the front surface of the lens, and typically in just the landing zone. And so the limitations to this design is that prism is thicker on one side, and patients sometimes can feel it, and they report discomfort. Additionally, if the patient has any kind of toricity, the lens is susceptible to moving. I actually prefer, if I have to do a front surface toric, to stabilize it by using toric landing zones. And so all of the lenses from BostonSight have toric landing zones, and so we can use this to our advantage. The way that this works is kind of like a key and lock. So when you create a bitoric corneal lens, those actually stabilize with the corneal toricity, and so those lock into place if there's enough corneal toricity. With a scleral contact lens, the back surface of the landing zone is toric, and that actually locks into place with the scleral toricity. And so the benefits of this is that it locks into place with the patient's scleral shape, and there's much better comfort. You don't have to deal with that uneven surface, and the patient is more comfortable. And I find personally with this design that the front surface toric actually stabilize much better. So I felt very comfortable actually adding a front surface toric onto this patient's lens, because when I placed lens 6 on each of his eyes, it stabilized, and it didn't rotate from where I placed it. So we're going to go back to those markings I talked about on the right and the left lens, with the 1 dot and the 2 dots. You actually follow where those are on the eye when you place the scleral lens on the eye, and you take your calipers on your slit lamp and you can measure in degrees where that aligns. And so where that aligns, you can place that in the fit connect with your cylindrical over-refraction, your spherical cylindrical over-refraction, and from there they know how to design the lens so that the front surface toric is in the correct orientation. And so for my patient, the right lens actually oriented right at 90 degrees, and the left lens, it did go a little bit counterclockwise and rotated to 110 degrees, but the lens was completely stable on blink and didn't move. So I was pretty confident when I placed a front surface toric on this lens that it wasn't going to move. And so this is what I ended up doing. This was the final fit on my patient. You can see here, nice even fluorescein pattern. And I was able to add that front surface toricity, and it had no rotation from where it was initially when we placed the tri lenses on. And with lens 6 and that over refraction, I was able to get him to 20/25 in the right eye and 20/30 in the left eye.
Perfect. So I'll go ahead and jump in on the last case. So in addition to these cases that we're talking about indications for irregular corneas, there are also therapeutic scleral lens indications that we can use, such as neurotrophic keratitis, exposure keratitis, persistent epithelial defects, graft-versus-host disease, Stevens-Johnson syndrome, ocular cicatricial pemphigoid, chemical burns, or limbal stem cell failure. All of these can result in severe ocular surface disease, and we can use these lenses as a way to protect the ocular surface by providing protection from mechanical involvement, and also to prevent desiccation of the tissue. And by doing so, we can allow the corneas to heal by breaking the pain cycle, and also by giving the corneas an ocular environment that is conducive to healing underneath the lens. So when we go ahead and let's see here and look at some literature on this, this was a great article and a couple of articles that have come out of the Boston Foundation for Sight, and these were talking about persistent epithelial defect management in individuals, and what they were doing was using a 24-hour wear strategy to help rehabilitate these corneas with these persistent epithelial defects. So the strategy that they would use is a 12-hour by 2 strategy. So you would put one lens on at 8 a.m. and go until 8 p.m. And then you would take the second lens out of the disinfectant solution, go ahead and clean that up, put that on from 8 p.m. and wear that overnight until 8 a.m. the next morning, which in that case, you'd go ahead and switch again to the clean lens and continue that cycle until the epithelial defect had resolved. And what they found was that most of these individuals with these persistent epithelial defects that were recalcitrant to treatment actually healed in an average of about 8 days. Now, the trick with this was with the first go around, there was about 4 of their cases that ended up with a microbial keratitis, and what they were filling the lens with was just straight saline at the time. Now, in their second study, they revised the strategy by adding non-preserved moxifloxacin to the saline before the individuals wore the lenses. And what they found was in this cohort that there were no individuals who developed microbial keratitis. So the important thing here is that you're putting the non-preserved moxifloxacin in the bowl, and specifically non-preserved antibiotic, for the ability to get the resolution of the cornea, but or rather the resolution of the defect, but also to cover as a prophylactic so that these individuals don't end up with a microbial keratitis. So this was my case that I had seen. This was a 64-year-old diabetic male who had a history of neurotrophic keratitis after having a herpetic keratitis. The patient also has exposure keratitis on the right eye and is monocular with a prosthesis on the left eye. So this poor individual is in bad shape, and his persistent epithelial defect was the result of a complicated cataract extraction on the right eye. By the time he had gotten in to see me, he had had the persistent epithelial defect for about 3 months. He was on moxifloxacin 4 times a day, had tried Procara to his protest because it would block his vision on the eye for multiple days, leaving him functionless. And the individual had also tried bandage contact lenses, which he was unable to retain. He was on autologous serum every 30 minutes, 20% autologous serum, and ointment at nighttime with a tape tarsorrhaphy. So when he got referred to me, he was referred by one of the cornea specialists in our office, and he said, "Look, our option is to either shut this eye with a full tarsorrhaphy and leave this poor guy blind, which we're not going to do, or we're going to go ahead and use the 12x2 scleral lens strategy for this individual," which is what we did. So what we started with for this individual, oh, by the way, this individual was 2,200 after that cataract surgery because of the persistent epithelial defect affecting his vision. So what we did was we took a 19mm BostonSight scleral lens. This was lens 5 from the fitting set, and what you can see is in the the horizontal meridian, you can see some impingement on the nasal and temporal side. The inferior portion looks like there's impingement on those vessels, but when you look at the superior portion of that haptic, the lens is actually decentering inferiorly a little bit because it is loose in the vertical haptic, or in the vertical meridian. So what we did for this individual was we flattened the horizontal meridian, so you can see meridian 2 here, and over on this side is meridian 4. And what we did was we flattened those meridians there about 250 microns. And then what we did was we reduced the sagittal depth because we were significantly overvaulting the cornea by 200 microns, and his over-refraction yielded a best corrected visual acuity of 20/50, even with that persistent epithelial defect present. So we went ahead and ordered 2 lenses on rush. These lenses actually got to the office within 48 hours of ordering, which was fantastic. The BostonSight team can really, get you lenses when you need them for these patients who are in need. And we used Optimum Extreme with tangible hydropeg coating. Now, this is really a testament to that data-driven design. You can see that this is a really good start point with the lens. There's really not much to do with it. So all we did was just make these minor corrections to these areas of the haptic. And this was our first lens. You can see that we have perfect alignment on the horizontal. When we looked at the vertical looked very good. So our plan with this individual was to do 12 hours by 2 scleral lens wear. So one lens from 8 a.m. to 8 p.m., the second lens from 8 p.m. to 8 a.m. With him sleeping in the lens. We were going to have this individual put a drop of moxifloxacin in the back of the bowl and 2 drops of autologous serum into the back of the bowl and top it off with unpreserved, unbuffered saline. Now, the use of the serum in the bowl was actually published in a study from Bascom Palmer. Dr. Priscilla Sotomayor had done a series of case studies that had looked at moxifloxacin and autologous serum in there for persistent epithelial defect management. Now, what we also did was to make sure that these lenses were as clean as possible. We put these lenses, or clean these lenses in clear care, but had them put into a deep well container instead of the neutralizing container that the clear care comes with. So the lens would sit in that non-neutralized peroxide for 8 hours a day, or 12 hours a day until that individual, it was time to wear that lens, at which time the patient would take the lens out, thoroughly clean the lens and soak the lens in saline so that there was no residual hydrogen peroxide. And we followed up with this individual in 24 hours to see how things were going and make sure that nothing was amiss with this cornea, since this is his only eye. So pre-wear, you can see the size of the defect and the size of the defect at day 3. We can see that he's clearly healing and healing quite well. Now, to measure this out, we used a software, a perimetry software that we have at our office from Advanced Ophthalmic Systems. Basically, we measured his HVID previously and then outlined the defect to find out the size of the epi defect that was present. So pre-wear, his epi defect size was 14.5 millimeters squared. On day 3, his epi defect was 7.6 millimeters squared. So what we found was their epithelial growth rate underneath the lens was 2.3 millimeters of epithelium every day. So by that calculation, we figured that he would be fully healed on day 7. So at day 3, I made the decision that I'm going to follow up with him on day 7. And lo and behold, on day 7, his epithelial defect is entirely cleared. His cornea looks nice and smooth at this point, and his visual acuity with the lens is 20/25 minus. Now, our plan from here was to discontinue the 12/2 strategy of scleral lens wear and go now to just daily wear strategy. And because he doesn't have any open defect anymore, we went ahead and stopped using the moxifloxacin in the bowl and stopped using the serum in the bowl. And we modified his nighttime therapies so that he's using a tape tarsorrhaphy at nighttime with ointment. And we followed up with him in 1 week with just the daily wear, and the defect was still resolved. So we decided that we were going to discontinue lens wear altogether, and this individual was able to, maintain a healthy ocular surface. So you can use these lenses for therapeutic purposes for these individuals who, may have a transient defect that you need to take care of. So for this individual, this was his pre-wear. You can note the injection of the conjunctiva, and at day 7, the lack of injection of that conjunctiva. And when we use our AOS software again, we can see that our pre-wear injection was a grade 1.1 by the software with 23% vessels present, whereas day 7 was 0.3 injection with 10% vessels present. So you can see a significant reduction in that injection of that eye. So really with these cases, you need to look at prudent choices and considerations. You need to evaluate the risk-benefit ratio and decide whether you're going to allow for surgery to be performed and kind of evaluate the risk of the surgery versus a scleral lens. You're going to modulate your scleral lens wear based on the individual's corneal characteristics and their response to wear, and then follow up frequently and monitor baselines for change, and work very closely with your care team to care for these individuals. And with that, I'll pass it back to Alan.
Thank you so much, Dr. Gellies and Dr. Forgozo. We're near the end, but I'd like to ask a couple questions. Actually, to Dr. Gellies, for the first patient where you use the eccentricity, do you find that most of the patients, do they do well with the built-in eccentricity, or do you find you have to change the value from FS1 to 0 or 2?
Well, I've looked at this very heavily and used the wavefront aberrometer to prove to myself that what I'm finding is indeed correct. And yes, I do find that the built-in FSE1 is over 90% of the lenses that I prescribe for these individuals. Saying that, for most of these individuals, you don't need to mess with the eccentricity. The built-in eccentricity is actually fantastic and gives the best visual results. So it's been extremely beneficial. Now, there have been a case or two where changing to a lower eccentricity or a higher eccentricity has definitely benefited the patient. So it's very much a kudos to BostonSight for including those options in the fitting set. But in general, the vast majority of individuals do very, very well with the FSE1, the built-in eccentricity.
The built-in one, yeah. So in your determination of whether or not to try, is it the pinhole measurement that if they attain better vision through a pinhole with an FS1, is that when you decide to try a 0 or a 2 eccentricity?
Typically, yes. So pinhole is one of the factors in this. The other one is for, in our clinic, we're heavy into the technology and heavy into research. So we have a lot of these toys for protocols. So part of our protocol on follow-up is to do a wavefront aberrometry measurement over the top of all the lenses. And even during the fittings, I'll do wavefront aberrometry to just see where I'm at. So if I feel like the RMS value is higher than I believe it should be, or I'm seeing more coma or more spherical aberration, then I'll go ahead and change the eccentricity and kind of give that as like a trigger for me to say, I should probably check this.
Right.
Yeah.
And how often would you incorporate a front surface cylinder or spherical cylinder over refraction?
So like Melanie, I start with a spherical over refraction to see how the individual responds to just the spherical, and then I proceed with a spherocylindrical over refraction afterwards to just see if I get any benefit from those individuals. I would say the vast majority of individuals don't tend to need the cylinder incorporation, but to Melanie's case, there are those individuals where that incorporation of that cylinder is really life-changing for them and really visually significant. And being able to incorporate that into a stable platform with the quadrant-specific abilities of the haptic and BostonSight Scleral, it really makes it really makes for a stable lens.
Great. Thank you. Thank you for your expertise in sharing that. Dr. Forgozo, can I ask you quickly, how was the comfort of your patient, the first patient, when you transitioned to the larger lens from the previous smaller scleral lens?
Much better. Actually, I find that patients actually appreciate larger diameter lenses for comfort in comparison to small diameter lenses. Her comfort level automatically increased when I was able to put a larger diameter lens on. And then also it really decreased the amount of pressure on her sclera, so we didn't see that impingement and that trenching on the shape. So much better.
Great, great. Let me go back to the presentation. Just to finish up, thank you all for attending. And we'll have another seminar in about 2 months. I'm just going to go to the very end here. And for those who have questions, whoops, I'm sorry. For those who have questions, by all means, please feel free to email us at BostonSight@bostonsight.org. And for those who don't have an account but would like to register, please go to fitconnect.bostonsightscleral.org. And by all means, if you have any questions, like I say, just email us and we'll be glad to reach out and answer any questions you may have. Thank you all for attending, and we hope to see you next time. Have a good night, everyone.